So first of all, navigation is near and dear to my heart, and I think it's really a foundation of cancer care, trying to provide patients and families with just direction. Sometimes people get lost in the system and the shuffle of so many, different facets of care and scheduling appointments and finding resources and education. So, I mean, just for the general oncology population, it's very important. But then when you look at the three populations that I looked at, which was specifically patients who live in rural areas, those who are American Indian, Native American, Alaska Native, and then that was the second population I looked at, and then those in other countries, low to middle income countries. I especially thought of those three kind of marginalized populations because of the low resources that exist. And because I've worked with all three of those populations too, I can really see considerable gaps that exist there because a lot of times there's no navigation programs out there in those areas. But the other thing I see is a lot of commonalities, which is interesting. Because when you look at like disparate populations or populations that are different than, the mainstream population, whether it's by distance, by culture, by poverty, whatever it is, then you do see a little bit of similarities in some of the things that they don't have. So that kind of gave me the motivation. And when I started writing it, they were all populations that I wanted to address. And to be honest, I wasn't sure about how I was going to weave them together. But then as I really started to think about what the literature was saying about each of these and then my experiences, it really kind of came together to kind of represent some of the gaps that are out there in navigation. I'll start with the rural piece because I'm born and raised in Montana. So I am like a rural girl. I grew up being rural. And early in my career, I saw some of the challenges where I was an oncology nurse my entire career, then became a clinical nurse specialist. And one of the things I recognized is that people would come in from out of town. And, there's only 1 million people in the state and 100,000 in Billings. So for them to come to the big city, find their way, find their appointments, that was even hard enough. And then finding resources in their community, like pharmacies. Where are they going to get their opioids? Where are they going to get their prescriptions? What if there's an emergency out there? So when I was a clinical nurse specialist, I really early on discovered the gaps that are out there. And as a clinical nurse specialist at the time, this was before navigation ever existed. I was like the point person for some of those rural patients that would come in. And then when we started developing our nurse navigation program, which we did at the Billings Clinic through the National Community Cancer Program, it was a big funded program. And we started developing navigation for those rural patients. It became immediately clear again at how they need somebody on the inside to help them navigate the system. Telemedicine has really helped to fill that gap in the rural area and such. Now, the other thing is the cancer disparities used to be very significant in the rural area where, the incidence was about the same, but patients were dying more often. They don't have good colonoscopy out there. They don't have good mammography. That's starting to improve. And in some rural communities, you're seeing like the results, you're seeing improvement in cancer survival, but that's not consistent across the board. There's still rural communities where the mortality rates are much higher than in urban populations. So again, trying to create awareness. The other thing is that with rural theory for rural populations, there's this insider-outsider theory where, sometimes they don't trust outside people from outside of the community. And so having somebody that they know so they can establish a relationship with the navigator who can kind of become their insider or somebody within the community that the navigator can work with. For example, another nurse in that community can sometimes be very helpful. So that's the rural community. For American Indians, I started my work with that population in about 1990, and I had gone to school at UC San Francisco, did a master's degree, moved back to Montana, and then I ended up working on the reservation. Somebody took me out there to really start looking at some of the cancer disparities. We tried to implement clinical trials out there, but nobody would enroll on a trial because they said if we talk about cancer, then we're going to be diagnosed with cancer. So we don't even want to talk about it. So at the time, nobody was screening for mammography. Nobody was doing, at the time we were doing prostate cancer screening, smoking rates were high, cervical cancer was high with HPV, and a lot of women were dying of cancer especially. So with that, again, using some of the community resources, tapping into experts, and having like this point person who helps guide care, we ended up, I had a team of 3 American Indian nurses who went to all 7 reservations in Montana, and we really started doing breast and cervical cancer education. We ended up with mobile mammography, and we increased the screening rates dramatically because at the time, many more women, American Indian women, were dying of cancer compared to the general population. I mean, the 5-year survival rate, I think when I started was like 50%. And that was, and now of course it's over 90% in most populations. That has increased considerably. It still is not that of the general population, but it's improving. But the other thing there too is still the cultural values to embrace, the insider-outsider, which is similar to rural health, understanding and having a perspective from the people. That's why even, having my 3 American Indian nurses was really beneficial because they knew the population, they grew up there, they knew people, they could help to kind of navigate and help patients to resources in what they needed. So again, another similarity. Then fast forward to some of my global health and going globally. So in low to middle income countries, I started working globally in about 2008 through the Oncology Nursing Society, and really went out to do work in pain and palliative care. Ended up working with the Middle Eastern Cancer Consortium, and it was kind of a treaty between 6 different countries. It was actually funded by the State Department and, well, the National Cancer Institute of the US, and really trying to provide resources to some of these low to middle income countries. Ended up doing a lot of work in Oman, and then I've also done some work in China and other parts of the Middle East as well. But some of the same things exist because even though they've got good cancer resources, they didn't have good coordination of care. And also there are a lot of misperceptions. For example, if you have cancer, people think you're automatically going to die of cancer. It's very taboo. So there's some consistency with the other populations too, as far as misinformation, fear about cancer. So we ended up training 400 nurses in that area in 19 different countries around the Middle East, including like Iran, Iraq, Pakistan, Egypt, all of those areas. And in a sense, sending those people out as kind of global ambassadors, which they're not formally navigators, but again, recognizing the importance of building people up within communities to try to do the work, because we can't really walk in their shoes because they have their own needs. And so I think the thing that I've had the privilege of doing is helping to facilitate building up in these communities with some of the inside people and the community members that can make it happen. Now, do gaps still exist? Yes, that's why I'm writing about it. In fact, now that work is with City of Hope. So we have some global initiatives trying to develop nursing navigation in Africa. Oh, and I did some work in Africa as well in Tanzania. So we also understand the importance of nursing. So nursing is the largest workforce in the world. We're the most trusted profession in the world. And we're also the most likely to be able to bring together patients and help connect them to resources. So in all of those three situations, nursing is really pivotal to putting the pieces together and tying, those resources together. So that's a lengthy explanation of the three, but those are the outcomes so far. And when you look at the literature, there's some navigation in some of the LMICs, the low to middle income countries, but there's a long ways to go. And when we do see navigators out there, here's what we see. It gets some patients to services more quickly because the healthcare systems are very segregated. It's like they have testing and then they'll have the test repeated here and the test repeated here. That's not so unlike the US, at least what we used to be 20 years ago. So fast forward, so this is 20 years back where this is happening in Africa. So the nurse navigator can help to really get a woman from breast cancer from diagnosis to treatment. And instead of waiting 4 months, we can try to shorten that gap to get people in sooner so that we can have better outcomes and better survival.